Assalamu alaikum. Our topic in this slideshow is preterm labor. The contents of this slideshow will include definitions, epidemiology incidence, complications, neonatal and maternal complications, causes and risk factors, prediction of preterm labor, prevention of preterm labor, and finally the treatment of preterm labor. We start with definition. The WHO definition of preterm labor in 2015 was as follows. It is defined as babies born alive before 37 weeks of pregnancy are completed. There are subtypes or subcategories of preterm labor based on gestational age. We start with extremely preterm when delivery of the baby is before 28th week of gestation. Very preterm between 28 to less than 32 weeks. Moderate to late preterm labor, gestational age is between 32 to less than 37. Induction or cesarean birth should not be planned before 39 weeks completed unless medically indicated. This diagram shows the subcategories of preterm labor according to the gestational age: extremely preterm, very preterm, less than 32, preterm between 32 and 36 plus 6 days, and term between 37 and 42, and post-term later on. Gestational age versus birth. Epidemiology of preterm birth. The source of this knowledge for epidemiology is fact sheet number 363 WHO. Every year, an estimated 15 millions of babies are born preterm, and this number is rising. Preterm birth complications are the leading cause of death among children under 5 years of age, responsible for nearly 1 million deaths in 2013. Three-quarters of them could be saved with current cost-effective interventions. Across 184 countries, the rate of preterm birth ranges from 5 to 18% of babies born. The above photo is a 26 weeks preterm, extremely preterm baby, and the photo below is a preterm also, but she is 35 years gestation, 35 weeks gestational age. There is rise in the incidence of preterm birth in past 20 years. However, delivery of babies less than 32 weeks remain constant, about 1 to 2%. Several factors have contributed to the overall rise in the incidence of preterm birth. These factors include increasing rates of multiple births, greater use of assisted reproductive technologies, and more obstetric interventions. What about the complications of preterm birth? Complications of preterm birth are simply divided into neonatal complications and maternal complications. We start with the neonatal complications, which are most important. Most mortality and morbidity are experienced by babies born before 34 weeks gestation. The major neonatal risks include neonatal death, respiratory distress syndrome, hypothermia, hypoglycemia, necrotizing enterocolitis, jaundice, infection, retinopathy of prematurity. And this is a baby in the intensive care undergoing mechanical ventilation because of respiratory distress syndrome. The outcome for infant live born before 26 weeks of gestation in British Isles as shown in this diagram. Gestational week when it is 22 weeks, the survival without handicap is only 0.7%. When the gestational age is 25 weeks, it rises to 23%. What are the causes of preterm labor or the risk factors leading to preterm birth? Multiple pregnancies, risk is 50% or more. Previous preterm birth, risk is 20 to 40%. Cigarette smoking, maternal cigarette smoking, risk is about 20 to 30%. Cervical incompetence, uterine anomalies, infections, bacterial vaginosis, twofold increase than the non-infected women. Young age of the mother, less than 16 years, lower socioeconomic status, reduced body mass index of the mother, less than 19 kilogram over square meter, antiphospholipid syndrome. Here, the preterm birth is induced for the risk of intrauterine fetal death due to placental insufficiency in cases of antiphospholipid syndrome. Obstetric complications including pregnancy-induced hypertension, antepartum hemorrhage, polyhydramnios, fetal anomalies. All these causes in item 10 and 11 are mostly induced preterm labor. Let's say iatrogenic preterm labor. This pie summarizes the causes of preterm birth in the form of cervical incompetence, spontaneous preterm, the majority of cases, multiple pregnancy about 20%, preterm, pre-labor, rupture of membrane about due to infection in most cases, in about 20% of cases, pregnancy associated hypertension, and so on. How to predict preterm labor? Prediction of preterm labor includes the following system for prediction. Consists of assessment of the risk factor in history, as mentioned before, vaginal examination to assess cervical status, which is a rough and old method, but still effective, ultrasound visualization, cervical length and dilation, and most important is the cervical length, detection of fetal fibronectin in cervicovaginal secretion. So, the program for prediction of preterm birth relies on four main pillars, complementary pillars. First is assessment, good assessment, thorough assessment of the history for searching for the risk factors mentioned before. Vaginal examination to assess the cervical status, ultrasound visualization and measurement of cervical length and dilation, detection of fetal fibronectin in cervicovaginal discharge. We start with the history. History of the all, we search for all the previously mentioned the risk factors. By examination, we should identify anemia, transvaginal cervical length, and fetal fibronectin, and chronic disease, debilitating disease. These are usually the most important points to stress on the case taking of your patient. The second item is vaginal examination. Digital examination is the traditional method used to detect cervical maturation, let's say effacement, but quantifying these changes is often difficult. It is a rough method. The third item, which is the most significant in prediction, is the transvaginal measurement of the cervical length, what's called transvaginal cervicometry. This table summarizes the relative risk and predictive value related to the cervical length. When the cervical length is less than 35 millimeter, the relative risk of preterm birth is only about 2%. If it is less than 30 millimeter, it rises the relative risk rises to about 4%. If the cervical length is less than 26 millimeters, it is 6%. When it is less than 22 millimeters, it is about 10%. If it is less than 13 millimeter, the relative risk is about 14%. The fourth item for screening is the fetal fibronectin testing in the cervicovaginal discharge or secretions. Fetal fibronectin is glycoprotein in the amniotic fluid or placental tissue, released because of damage of the membrane of the placenta, measured from the cervical or vaginal swabs. If the fetal fibronectin estimation is negative predictive value of about 99%. So it is a good negative, not a good positive test. If it is positive, the positive predictive value about 13 to 30, very low. It is not a positive, a good positive, but it is a good negative test. 99% of symptomatic women with negative fetal fibronectin are undelivered at 7 days of testing. In most cases, about 100%. 99.2% of symptomatic women with negative fetal fibronectin are undelivered at 14%. 14 days, sorry, 14 days. So 99.5 of symptomatic women with negative as were undelivered at 7 days. If the percent is decreased by 0.3 only and become 99.2, the prolongation of pregnancy in these women increased. They are not delivered in 14 days of testing. So prediction of preterm birth relies on four main pillars: history, taking, and examination for detection of risk factors. Second, digital evaluation of the cervix for maturation and length and dilation. Third is transvaginal cervicometry. Fourth, testing of fetal fibronectin in cervicovaginal secretions. What about the prevention of preterm labor? Prevention in general is either primary, secondary, or tertiary prevention. Primary prevention of preterm birth aimed to the general population has been insufficiently studied. It includes family planning, prevention of pregnancy from the start, avoidance of life cycle risks, and proper nutrition. And this is insufficiently studied in the population, general population. Secondary prevention include management for prevention of preterm birth is mostly secondary prevention, and it is based on identification and treatment of the risk factors or treatment of symptomatic women with preterm birth or premature rupture of fetal membranes that include the tertiary prevention after occurrence of the event. Secondary prevention of preterm birth has been effective in the following groups of for the following interventions. Let's say prevention of the risk factors. In women who smoke, smoking cessation, and counseling and support groups and programs. In women with one or more prior spontaneous preterm birth, now carrying a singleton gestation, the following interventions are recommended. 17-hydroxyprogesterone caproate, 250 milligram intramuscular every week, starting at 16 to 16 to 20 weeks until 36 weeks. Cerclage if cervical length is less than 25 millimeters before the 20th week. Let's say between 14 and 30, 23 weeks. Omega-3 fatty acids may have a role in prevention of preterm birth. In women with 3 or more prior preterm birth or second trimester losses, history indicated cerclage is indicated. In women with asymptomatic bacteriuria of more than 100,000 bacteria per milliliter, colony per milliliter, appropriate antibiotics are given. In women with asymptomatic group B streptococci bacteriuria of any colony count, even if less than 100,000, appropriate antibiotic is indicated, usually penicillins. The supplemental progesterone used for prevention of preterm labor may be progesterone intramuscular injections. Usually the dose is 100 milligram ampoule. 17-hydroxyprogesterone in debut form given weekly. Vaginal progesterone pessaries and creams. Oral micronized progesterone, which proved less effective than the vaginal progesterone or dydrogesterone, and it is now not a priority in indication for prevention of preterm birth. We start in the second trimester, continue at 36 weeks if prior delivery before 34 weeks. 17-hydroxyprogesterone use is in high-risk women reduced preterm labor in one study by 15 to 70% of cases. How to diagnose the established preterm labor, or what's called previously inevitable preterm labor? We have 3 criteria to document the occurrence of preterm labor. Regular uterine contractions occur at 4 contractions per 20 minutes or 8 contractions every hour, plus progressive change in the cervix, progressive effacement and dilation of the cervix. Second, cervical dilation is more than 1 centimeter. Here we mean the dilation of the internal cervical os, not the external cervical os. Third item is cervical effacement. What's meant by effacement? Effacement is the abolishment of the cervical canal length. That's to say, it is the taking up of the cervical canal into the lower uterine to form the lower uterine segment. So, documentation of preterm birth depends on 3 criteria: regular uterine contractions, cervical dilation more than 1 centimeter, and cervical effacement 80% or more. Women with preterm labor but negative fetal fibronectin and transvaginal ultrasound cervical length more than 30 millimeter have a very low chance of delivering within 1 week and a good chance for delivering more than 35% without therapy and should therefore not receive any treatment. Again, this paragraph is important. Women with preterm birth but negative fetal fibronectin and transvaginal ultrasound is more than 3 centimeters have a less chance than 2%, 2% chance of delivering in 1 week, and a 95% chance of delivering more than 35 weeks without therapy. Treatments of preterm labor constitutes the trying to abolishment uterine contractions by drugs in a group termed tocolytics. Tocolysis means inhibition of myometrial contractility. The drug causes tocolysis is tocolytic. The tocolytic agents used in obstetric practice include magnesium salts, terbutaline, which is a selective beta receptor agonist, indomethacin, which is prostaglandin synthase inhibitor, nifedipine, which is a calcium channel blocker, atosiban, which is selective oxytocin receptor inhibitor. It is the most specific tocolytic. However, tocolysis or tocolytic agents are contraindicated in intrauterine fetal death or lethal fetal malformations or anomalies or non-reassuring fetal heart tracing. It is contraindicated in severe intrauterine growth restriction, chorioamnitis, and antepartum hemorrhage. It contraindicated also in severe preeclampsia. Terbutaline increased cyclic AMP and decreased intracellular calcium. Indomethacin decreased prostaglandin production, and nifedipine blocks calcium influx. Tocolytics should not be used without concomitant use of corticosteroid for enhancement of fetal lung maturation. No tocolytic has been shown to improve perinatal mortality. There is no tocolytic agent that is most safe and efficacious. Cyclooxygenase inhibitor, COX inhibitor, are the only class of primary tocolytic shown to decrease preterm birth less than 37 weeks compared with the placebo. COX inhibitor, beta mimetics, and oxytocin receptor antagonists have been shown to significantly prolong pregnancy at 48 hours and 7 days compared to the placebo. COX inhibitor, calcium channel blockers, and oxytocin receptor antagonists have significantly less side effect than beta mimetics, which causes pulmonary edema, maternal pulmonary edema. There is no maintenance to colitic that prevent preterm birth or perinatal morbidity or mortality. There is insufficient evidence to evaluate multiple tocolytic agents for primary tocolysis. Refractory primary agent is failing, so another is started. Tocolysis or repeated after successful primary tocolysis. What about the evidence-based medicine in tocolysis? Tocolytic drugs should be used in women with suspected preterm labor with otherwise uncomplicated pregnancy, women with preterm labor needing transfer to a hospital that provide neonatal intensive care, or those who have not yet completed a full course of corticosteroid. Effectiveness of tocolytic drugs according to the evidence-based medicine, nifedipine and atosiban have a comparable effectiveness in delaying birth for up to 7 days. And this is a strong recommendation by the Green Top guidelines of the Royal College. Compared with beta agonists, nifedipine is associated with improvement in the neonatal outcome, although there are no long-term data. And according to the evidence about the adverse effect of tocolytic drugs, beta agonists have a high frequency of adverse effect. Nifedipine, atosiban, and COX inhibitors have fewer types of adverse effects. The most risky is beta agonist, causing pulmonary edema. Using multiple tocolytic drugs appear to be associated with a higher risk of adverse effect and so should be avoided. The recommended doses regimen for nifedipine and atosiban. Nifedipine, initial oral dose of 20 milligram followed by 10 to 20 milligrams 3 or 4 times daily, adjusted according to uterine contractility for up to 48 hours. A total dose of 60 milligram is associated with 3 to 4 fold increase in the adverse effect. Atosiban, an initial bolus dose of 6.75 milligram over 1 minute, followed by infusion of 18 milligram per hour for 3 hours, then 6 milligram per hour for up to 45 hours to maximum of 330 milligrams. Corticosteroid betamethasone 12 milligram intramuscular every 24 hours for 2 doses between 24 and 34 weeks is preferred if available, given to the mother prior to preterm birth, either spontaneous or indicated, are effective of preventing respiratory distress syndrome, intraventricular hemorrhage, and neonatal mortality. Dexamethasone, when betamethasone is not available, 24 milligrams intramuscular in divided doses is a second choice if betamethasone is not available, as in our locality. Maximum benefit if the woman delivered after 24 hours to 7 days after treatment. This is about the corticosteroid glucocorticoid role in management of preterm birth. Cervical cerclage. For all decisions about cerclage are difficult and should be made with the senior involvement. A doctor with necessary skills and expertise to perform cerclage should carry out the procedure. Types cerclage of the terminology according to the indication: history indicated cerclage, ultrasound indicated cerclage. And here we reach the end of our lecture. Wishing you all the best of luck, and thank you very much.